All right, so to continue on our ENT journey, I thought I would talk about how to handle not only grossly what to do about these ENT frozen specimens, but also how to think about them microscopically and how to sort of put them all together into the context of a sign-out synoptic report, because there has been some confusion lately about how to handle them and how to think about them, not only from you guys, but from some of the faculty as well. So I might end up sharing some of this information with them just so that they know, basically what I'm asking you to do at the time of frozen so that we're all on the same page. Again, if you guys have comments or questions or whatever, just please, I'll have my chat open and, or just speak out. All right, so often in the gross room, we get the main specimen, right, as a frozen. And basically what they want to know are potentially one of a few things. These can either happen for mucosal ellipses, like mostly tongues, or even for cutaneous squamous cell carcinomas. Generally, it's for squamous. Occasionally, you might really get a case for basal, but generally these come for squam. What they want to know are a few things. One is there potentially any severe dysplasia or carcinoma in situ at the mucosal edge? Is there any invasive carcinoma at any of the peripheral margins? And is there any invasive carcinoma at or near the deep margin? And so I've sort of simplified the ellipse with these drawings to maybe help us kind of clarify what we're going to do. Sometimes they want to know the depth of tumor invasion in order to determine if the patient's going to get a lymph node dissection or not. Excuse me, let me get my water. So what kind of numeric and conceptual cutoffs are important? So for the mucosal margins, it's going to be usually anything on the high grade. If it's mild dysplasia, mild to moderate dysplasia, that's not an indication for continued resection of that mucosal edge. Only if it's on the higher end, moderate to severe, severe carcinoma in situ at that mucosal edge. Because as you know, these things spread along the mucosa and they want to get as much as they can out. All right. Secondly, the invasive component. So for the peripheral and the deep soft tissue margins, usually in the tongue, right? This is going to be muscle. This is going to be lingual skeletal muscle. Pretty much anything within about 5 millimeters of the margin, I would consider somewhat worrisome enough to freeze. So there's not always a perfect cutoff for what each surgeon is going to use for each individual patient. But the thing we do know is that 1 millimeter or less is essentially positive. Okay, so if you are that close, that's positive, and you should essentially freeze it and or just give them a very, 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 very close gross answer. Anything about 3 millimeters or so is kind of starting to, do we take more, do we not? That's the surgeon's kind of decision. And then anything, 5 or more is generally grossly free is fine. So as I said, this kind of depends on the patient, the physician, the clinical setting, but those are the things we want to keep in mind for when and where to freeze and why it's important. For depth of invasion for neck dissection, it's essentially 3 millimeters or more. So it's thought that depth of invasion of invasive carcinoma predicts regional lymph node metastasis. So less than 3, they won't do a prophylactic neck dissection in the setting of a clinically and radiographically negative neck. They will leave it alone. If there's a positive neck clinically, of course they'll take it. Then the depth of invasion doesn't matter. But we're talking about a clinically and radiographically negative neck, 3 millimeters or more, your risk for nodal metastases is increased. Therefore, they will do a neck dissection. And generally, if it's a unilateral lesion, they'll do a unilateral neck. If it's a midline lesion or it sort of crosses, they will potentially do a bilateral neck, because as we know, the pattern of lymphatic drainage of the tongue starts to kind of cross over in the midline, and so it can go to either side. All right, questions so far?
Nope.
All right, so what do we do when we get these specimens? I've already referred you yesterday to the link in my email, to the link in the website, but here it is again. And we're going to go over it in much more detail today, but that's your general overview. So first, of course, we want to orient the specimen, and generally they suture it, long, lateral, short anterior or something like that. So depending where you are in the mouth, your numeric clock face can be different depending on the anatomic orientation. And so unless you have no way of determining anatomic orientation, if you have no way of determining anatomic orientation, you can use clock face. But if you can determine anatomic orientation, it is preferred. So we know exactly what we're doing, right? So if this is your tongue, right? This is the dorsal surface. This is the tip. Underneath is the ventral surface. As you go forward down, you're onto the floor of mouth. Yes? All right. These are the lateral borders of tongue. Way back here is the base of tongue. Okay. So you know that if you're on the ventral surface of tongue, your mucosa is essentially oriented ventrally or superiorly, right? You have an anterior, a posterior, a right and a left. And if it's a unilateral tongue lesion, you sort of have a more towards lateral and more towards midline, right? Depending on where you are. If you're in a midline location, then you have a right and a left, okay? So medial and a lateral don't really make sense if you're in the middle of the specimen. If you're on one side of the specimen, then it would be a medial and a lateral, do make sense, okay? If you're on the lateral borders, right, your mucosa is going to be lateral and your anatomic orientation will shift such that your mucosal edges are going to be like superior and inferior and anterior and posterior, and your deeps are going to be essentially towards the center, right? If you're on the ventral surface of the tongue, your deep, right, your deep soft tissue margin is actually going to be facing up, right? So we just have to keep all these things in context when we're looking at where we are. If you can't figure that out, clock faces are fine. 12, 3, 6, 9. Oops, excuse me. All right, so what do I want to see here? Inking. So for most sections, for most specimens, I generally advocate essentially only 2 colors. If it's a relatively straightforward ellipse of excision, because you're going to tell me in your cassette summary what's the 12 o'clock tip. For sake of convenience, we're just going to use numbers, right? You're going to tell me what the 12 o'clock tip is in your cassette summary. You're going to tell me what the 6 o'clock tip is in your cassette summary. The colors are going to tell us what's 3 and 9. And the shape of the tissue is essentially going to tell us what's a peripheral margin and what's a deep margin. So I know we've had this conversation in the gross room with a number of you where surgeons request different colors for different things and they only care about this, not that. Well, I know it can be hard to interact sometimes when the surgeon is telling you how to ink it, but I would try your best to, if it's a very difficult situation, give me a call. But otherwise, try and follow the regular guidelines. And as you can see here, hopefully why we use these routine guidelines. All right. So essentially, you're going to ink, as you know, the 3 o'clock half, both the peripheral and the deep, one color. The 9 o'clock half, both the peripheral and the deep, a second color. Usually black and blue are preferred just because those stick to the tissue the best. They're easy to see on the slide. Right? And you're going to cover everything that's not mucosa or skin, right? You're going to cover soft tissue, fat, etc. Okay, I think you're all familiar with this. When you get this for frozen, even if the surgeon says, I'm worried about that area, you're going to say, thank you very much. I'm going to section the specimen and we will evaluate that deep area. So you're going to serially section the specimen fresh as if you were grossing it for permanence. And I know this can be technically challenging when the specimen is soft and squishy, but it is the only way to evaluate all margins appropriately. So here's an example of a tongue. I think this is the one that's on the website where it's oriented with long and short sutures. You've inked it, blue and black appropriately, and you've serially sectioned it perpendicular to the long axis, right? With your tip A in slice 1 and your tip B in slice 8. And you can see the caps, 1 and 8 are the caps with the ink, okay? And the remainder of your slices are seen here. It is only in this manner that you can actually evaluate the cross sections of each slice and determine what to freeze.
Are they still asking us to do the liquid nitrogen?
They who?
ENT surgeons.
So they only asked about that because I suggested it as a technique for people who are uncomfortable sectioning fresh specimens to help firm up the tissue. So it's not, I know that they were quote unquote asking for it before, but that was because I had discussed it with some of the residents and them regarding facility of sectioning. So I don't think they have not been mentioning it, but I'm going to talk about why we may or may not use it.
Okay.
Yeah. So that'll be on the next slide. So regarding those tips, so I've talked to some of you about actually taking your first and your last tip slices, in this case 1 and 8, a little bit like thicker, mostly because you're going to end up perpendicularly sectioning them, right? And so let me annotate here, when histology cuts these, if they are, why can't I draw? Let me draw. Oh, there we go. If histology cuts these, when they embed and cut them, if you cut it really, really narrow and give them tiny little pieces, it's actually harder for them to embed nicely so that we see, mucosa, margin, cut. If you cut that tip a little bit deeper, your slices are a little bit longer and essentially just easier for them to embed and therefore easier for us to see the approach to margin. Does that make sense? So this is fine if the thickness of your tips is deeper or thicker than the thickness of your individual slices, because remember, we're going to be embedding these in different ways. So that's all I have to say about that. Questions? Okay.
Do you care if, because you took a thick tip section and that you have to split your tip margin or your tips into multiple cassettes?
Yeah, so good question. So in the end, right, when you're going to be cassetting these, for actual skin or mucosal slices, we essentially advocate 1 slice per cassette, again, for embedding and cutting reasons. For margins, because they're smaller, I'll allow a few more, 2, maybe even up to 3, but always be mindful that the more pieces you put in a cassette, the harder it is for histology to embed it, because as they're embedding it, the wax is like drying and not drying, cooling, I should say. And the slices are now like stacking, right? And so the fewer you have, the more close they are to even, and the better they are to get a full face. So yes.
Also for first years about the embedding, because I know we often did it with the prostates as well, with the apex and base, that when you do perpendicular and then you want to embed on edge, you can make a note in Vantage, because sometimes the little pieces roll around in the cassettes and it ends up being embedded not the way that you put it in. So if you are really worried, just put that, take that 5 seconds to put that note in Vantage for histology.
Cool. So regarding liquid nitrogen, so on the website and in person to some of you, I have discussed when or if to immerse a fresh specimen in liquid nitrogen to firm it up for cutting. So I know that some of the PAs and some of the residents are very comfortable cutting these tongue specimens freshly. I know if you have questions, Corey is always very helpful with physical tactics to cut these nicely regarding pressure and slicing. If it's challenging for you, I will allow you to sort of lightly immerse the tongue or skin ellipse in liquid nitrogen, basically to firm it up to prevent like slippage between tissue planes and like weird sections. And so here's an example of Kyle, who used to use this technique, who liked it and was successful at it. And I actually believe that the photos you saw in the prior were from a liquid nitrogen specimen. So he, froze it, cut it, let the slices thaw, which doesn't take very long. And this is a photograph of the post-thawed pre-frozen, right? This, as you can see, it's completely intact. Nothing has been taken for frozen yet. So this is a very nice documentation of, hey, here's what we saw grossly overall. Here are what my slices looked like before I froze anything. All right. And then we're going to freeze something. So does this all make sense? If you guys need help, ask me, ask a PA. But I will leave this up to your discretion, whether you want to use it or not. If you want to practice on like a skin ellipse from like an amputation or something, you could do that as well. All right, so now you have your slices lined out. In this case, I just have 7. What will you freeze? So does anybody want to tell me or chat in which slices they're worried about for margin?
Number 4 for the deep, and then number 3 for, I guess that's your 3 o'clock. Oh no, it's 6 o'clock.
Black,
Sorry, other way.
Right, so we've
Or
got
9 o'clock.
Right, some people are saying 3 and 4. Okay, good. So yeah, so you want to be careful not only for the deep, but also for the peripheral, right? And so I agree that 4 is the closest to deep. So you're going to want to freeze, if not that entire slice, at least the portion with the deepest margin, right? And for 3, you are going to want to freeze at least that peripheral half, the black half showing the closest to the peripheral margin. So if the slices are small and you can fit them, thanks, Faiza, I will address that. Good point. You can freeze the entire slice if it fits in a chuck. If it doesn't fit in a chuck, you can isolate the section of interest, and later you're going to tell me what you froze. Okay, so good. And there's question marks, as you can see, by 1 and question marks by 7. And Faiza said definitely 1. So what do we do about the caps, right? So if you essentially see no tumor in your cap slice, I would say you don't have to now perpendicularly section it. If you do see a significant amount of tumor in your cap slice, like number 1, then you're going to want to perpendicularly section those and evaluate those tips, because don't forget that is a margin, right? So I don't have an image of it, but once you have your perpendicular tip slices, you're going to want to look at those and see if anything is also close to 12 o'clock and freeze that if it is, all right, using the same criteria, about 5 or less-ish millimeters. Okay, so good pickup on that one. Hold on, let me get rid of this. Okay, so what does it mean when we talk about the main specimen versus the tumor bed margins? So what we have just discussed are the main specimen margins, okay? We do that because we get the advantage of seeing where the tumor is and seeing where it's closest, okay? They only can palpate, right? They're not cutting into tumor. They don't want to cut into tumor. All they do is know where it is based on the CT scans, know where it is based on palpation and anatomic location, and they cut around it, right? So sometimes, as you know, they will also send these tumor bed margins, which are strips of tissue taken from the edge of the cavity left in the patient. Those are tumor bed margins, and those are generally important when we do our synoptic reports. Okay, so here is diagrammatically how the tumor bed margins relate to the main specimen, right? So they basically take strips of mucosa and sometimes, deep tissue from that cavity, from the edge of that cavity that's left in the patient. So it's one extra step outside of the main specimen. Sometimes also to include the deep, which I haven't pictured here, but you can imagine that. Conceptually, the piece of the mucosa and soft tissue that's closest to the actual specimen is not the margin, right? But the piece of mucosa and soft tissue that's away, that they cut from the patient, right, is the new true margin. But we don't always have that orientation. Like when they send us a strip that says 3 o'clock margin or lateral margin, freeze it, we don't know which end is up, right? Like they don't often orient it. Is that correct?
Yeah, I would agree.
Right. It's just a strip. So we don't know which came in contact with the patient. So we're guessing. So it's always a little bit of a guessing game unless they orient it, but you just freeze it. Okay. But theoretically, it also has a direction, right? But since we don't know that direction, we can't provide them that information. Okay. Sometimes when they take a huge new strip of margin, they will sometimes orient, you know, this side is new true margin, this side is cavity. Then we're going to ink that, and that's going to be important. But for these frozens, usually we don't. Okay. So tumor within anywhere between up to 1 and 3 millimeters of a perpendicular margin, right? Or just present in the en face tumor bed margin will likely prompt re-excision of that margin. So if you think about it, what we are taking from the main specimen are perpendicular margins. There we can give them a distance. What they are sending on the tumor bed margin that we're just embedding is en face. So anything in that section present is positive. Yes? Okay. So depending on distance or positivity, they may re-excise that particular piece of margin, okay? So number one is, yes, your margin is positive at frozen, go back. Usually what GUI and Agrawal will do is they will send another strip of tissue from that section just for permanent, and you don't see it until later. Then the third strip will be the final margin that they will then send to you for frozen and say, now tell me if this is positive. Right? So if you give them a positive margin on any case, expect essentially another 2 specimens, right? The one you called positive is number 1, and then the extra 2 are the permanent that they send that you don't see until later, and then the last frozen, right? So it usually comes in these pairs, if that makes sense. So we have to put all these things together when we finally do the synoptic report. Do we have any questions before I go into the synoptic? So our synoptic and copath is essentially based on CAP. So here's a link to the CAP cancer templates. We use these for all cancer specimens. Here's the one that we're going to be talking about that includes the lip and oral cavity. And these get updated every few years. So, you know, just keep checking back. They specify that they want to know the main specimen margins, right, which is the actual specimen, and then the tumor bed margins, which now you know what tumor bed margins are, okay? So as I said, we don't generally know tumor bed margin orientation. We don't know up from down on those en face ones, but we do know, so we don't usually report this middle block, but we do report the top block about specimen margins, and we do report the bottom block about tumor bed margins, whether they are involved or uninvolved, to come up with a final determination of margin status. Okay. Because if you have a positive main specimen margin, you could still have a negative final margin if those additional tumor beds were negative. Okay. It is generally thought that the margins obtained from the main specimen are of better value because we know exactly how they relate to everything. The tumor bed margins, you know, whether they come from here or here or here, can sometimes not be known between us and between the surgeon. Only the surgeon really knows where he took that little strip from. I think it's especially relevant when it comes to a deep margin, right? So if you think about it, often these specimens are decently sized, right? At least a few centimeters long. And sometimes they send for deep margin, right? They send like a fleck of tissue that's no bigger than my fingernail, right? But that doesn't cover the entire deep margin of that specimen. So if you have a positive deep margin and a negative deep margin nail bed size, right? I don't know where that nail bed size tissue came from. So I can't tell them whether that's a clean margin or not, right? And I think we've discussed this with some of you. I think it's pretty, you know, conceptually clear why this is a challenge. So again, in multi-part resections, the pathologist's ability to establish the margin can be challenging or compromised because of uncertainty of where all these things relate. That's why if there's an issue, we often communicate this directly and in person and in showing images of the specimen with the surgeon so that they know exactly what we're talking about. Because if we say, over here near 3, that doesn't mean necessarily a lot to them. They want to see what it looked like where in the patient. All right. So we have, and we do show them those gross photographs of the specimen, both of the overview and of the cut slices. Sometimes if it's close, that's why photographing these things isn't just like for me, for my shits and giggles, right? It's like, this is clinically important because often we do have to go back and show the surgeons these photographs for where their margins are close. And they really, really appreciate that, and it helps them go back knowing better where to go back in the patient if they're going to do a second operation. So thank you for taking those photos. It has been very, very helpful, and please continue to do that. Okay, any questions right now? All right. What about depth of invasion? Okay, 8:30, good. So we're nearing the end of this PowerPoint. So how do we measure depth of invasion, and what is the important depth cutoff? We already said about 3 millimeters in depth of invasion. So depth of invasion is different than tumor thickness. Okay, so tumor thickness is the entire tumor from top to bottom, regardless of where it starts and ends. Depth of invasion is measured only from the adjacent normal basement membrane to the deepest point of tumor invasion. Therefore, if this is an exophytic tumor, it is thicker than it is deep, all right? And for staging purposes, we only want depth of invasion, i.e. measured from adjacent normal basement membrane. And this, again, can be very, very challenging if you don't have adjacent normal basement membrane. Therefore, if you're freezing a specimen for depth of invasion, right, to determine neck dissection, please try to have some normal on the side. And if that means you have to section through the center of it and freeze 2 halves, that's okay. But we need that adjacent normal to measure DOI. Otherwise, you're stuck because you don't know what's exophytic and what's endophytic. All right. Again, just to recapitulate, thickness is the entire from the tip to the base. DOI is only basement membrane to base. And here's how an example from the CAP guidelines of how you draw that so-called horizon line and then the plumb line down. And we've done this on our slides at times during sign out with some of you. Here's another example showing, rather than an exophytic lesion, an ulcerated lesion, where the thickness is actually thinner than the depth in places, right, because of the ulceration. Here's an example of a frozen section that is lovely because the tissue was small enough that it all fit on one slide. You were able to measure both the depth of invasion from the basement membrane to the deepest, as well as the distance to margin. All right, so this is a rare example of kind of where it all came in one slide, but we don't always get that. Okay, so after you've done all these mega frozens for this patient, ideally, since the specimen has already been serially sectioned, i.e., grossed, it should essentially be grossed, like placed into cassettes and documented in COPATH as soon as possible by whoever did the sectioning. And I think that transitioning this to another person when absolutely necessary, you can do, but I really, really ask and advocate that if you've already done this amount of work, just finish it, because wrapping it up, placing numbers on a piece of paper, transferring it to another person, they don't know what you did, not having adequate triage notes, like it can get very confusing. And sometimes wrapping up of those slices makes them wavy. And so then when you embed them in the cassettes, they're harder to section in histology. So please, if you can, please just gross these as soon as you can, freshly. Have them sit in formalin, have the cassettes sit in formalin for a little bit before you submit them, because it's still essentially an unfixed tissue, right? Anybody, or was that a mistake?
That is true. Sorry, I'm just gonna zoom out.
No, okay. All right, so if you haven't perpendicularly sectioned your margins at the time of frozen, you should do so. And as we talked about before, you should submit only a couple per cassette for ease of embedding. Your sections should be submitted, aside from the frozens, which you submit up front, right? The remainder of your sections should be submitted sequentially with slice numbers. And that goes back, that helps us if we need to go back, if the size of the tumor was a little bit difficult to determine on gross, we go back like you guys do with breast lumpectomies, right? Where you divide and multiply across the number of slices to determine the tumor size. So this is why the numbers are helpful, and the submission with numbers is very critical. So if it's a small-ish specimen like this, I would say just submit it entirely and sequentially. If it's larger, you may want to discuss this with us. Consider submitting every other or every third slice. Certainly, if you're going to do this technique, you're going to want to do the entire slice, right? Don't say, okay, I'm going to do a lateral half of 4 and the medial half of 5 and just do a whole slice. So it's just easy to walk through, and it's easy to go back to if we need to go submit more. Certainly submit all slices with closest to all margins. If the, what am I saying? Oh, if the tips are big, like wide, you don't have to submit the entire tip. I know that like in breast, right, they want you to basically submit the entire medial and the entire lateral margin. But for most of these specimens where you could actually see the tumor and you look at the tip and you say, oh, there's not much in here, you don't have to submit the whole thing. Like that's a fallacy. It's okay. You can also just do if you're doing representatives of the entire specimen, you can also do representatives of those tips. Does that make sense? Okay. When you're doing your cassette summary, always state what you did to the specimen, what you froze at the time of frozen, and then what and how you submitted it later. So this is a pretty good example of kind of what we're looking for, right? We want that you got it for frozen. We want the orientation. We want the measurements in anatomic orientation, or at least in clock face orientation, right? Which direction is which length, which half you inked which color. I know this can be sometimes confusing because I have two different brackets, one for mucosal lesion size and one for mass lesion size. The only reason I do that is because sometimes what you see on the surface is not really representative of what's underneath. And sometimes you have a small ulcer, but like a really big tumor that you on cut sections that underlies the ulcer. And sometimes it's the opposite. Sometimes the ulcer is huge and all you have is a tiny little dip of invasive carcinoma. So sometimes the surface versus the cut section lesion can be disparate. Therefore, it's nice to sort of report them differently. But don't forget that once you serially section those slices and you see something on the cut sections, don't forget to reapproximate them and measure the distance across slices. So we have that third dimension, not just the two. As I said before, it's very excellent when you number those slices. It's also excellent when you tell me, you know, I've frozen a representative 4 and a representative 8 here in A1FS and A2FS. And then you go through and you say, okay, here's my remainder. 1, 2, 3, remainder of 4, 5, 6, 7, remainder of 8. Okay, so this is kind of the general gist of what we want to see. And when you're taking your photographs, as I said, it's great if you have a photograph of the intact specimen, a photograph of the cut sections, even that entire overview like I showed before. But then certainly if there's a section with prominent tumor closest to margin, you're going to want to isolate and only photograph close up the ones that have the sort of the best or the most representative tumor. Because when it's panned out in bird's eye view, it can be hard to see those fine details. So just also do that. You can do it, you know, after the fact. You don't have to necessarily do all of this right up front, but if you're going to freeze something that's very, very close to margin, I would advocate you potentially take a photograph of it before you freeze it so we know what it looked like and why you chose that particular section. I know it takes up some of your time, but the ENT surgeons aren't generally very anxious about time because they're doing neck dissections or doing other things. So if you encounter problems, just let me know, but this is my general gist. So, all right, I'm going to stop my share. Do you guys have questions before I move on?
No, doesn't look like it.
Okay. So I've given you some, so 20 minutes, good. So I've given you some slides of some issues and some challenges that can be encountered during frozen section. The PowerPoint I have now is a little bit longer because I have also permanent correlates. The one I gave you yesterday, I think, was only the frozens. Hopefully you were able to make some heads or tails out of what you saw. So this is I'm going to rotate it. I love this thing. This is a section of a tumor for margins. It's, as you can see, it's obviously already very deep, right? So here's the surface and here's the tumor. So they're not concerned about depth of invasion in this specimen. They already know it's big. They are concerned though about distance to margin. And so if you can imagine, this is essentially the normal-ish mucosal surface on the right side. Ooh, can I magnify that? Yeah, I'm gonna maximize that, great. And this is the tumor on the left. You can see that there's some blue ink right here at the bottom, so they've inked it appropriately. You can see though that the blue ink kind of goes away a little bit here near the base of this tumor. And then it maybe, if you look closely, picks up here at the edge. So when you guys are looking at these frozens, you know, with the attending, be very careful that your frozen section is also full face, right? That you get that complete margin. And that you look carefully for the ink so you know where your actual margin is, right? So I would argue that this margin is relatively farther. However, excuse me, harder with a trackpad. This margin over here is arguably relatively close. And so one would want to measure the distance to margin as this blue ink to this start of tumor. I know there's some inflammatory infiltrate, right? But essentially, you know, this is where the tumor is. So this is your nearest to margin. And so I don't know, there's no measuring tool on this, I don't think, but you can see how it's quite close, right? And so this, unfortunately, I don't know if this was given a distance, was not given a distance. There was some confusion about this specimen, but regardless, the point is, be very clear what you're telling the surgeon, even if it's negative, right? Like technically, this is not cutting through tumor. This is a negative margin. But in this context, what do we know is important? Definitely 1, perhaps up to 3 or so millimeters. So in this case, you are going to want to give them an exact measurement. Like this is 1 millimeter from margin. This is essentially a positive margin. Okay, let me counter that with, if you are evaluating the gross specimen and you don't see any tumor, like sometimes these are tiny little microinvasive carcinomas, you can call them up and say, listen, there's grossly nothing near margin. Like, I don't want to freeze anything. I'm not going to freeze it. We've done that. That's okay. Like, they accept that. So consider that always if you don't have anything. But if you do have something that's close, please be as specific as possible when you're telling them how close and where it is. The problem with this was that this was not understood to be close or you know, positive. These next section, not the permanent remnant from this, but the section next in the specimen had this, okay? And I know you guys didn't get to see the permanent slide here because I didn't give it to you, but if you can imagine, right? This is basically the next slice over, same thing. There's kind of normal on the right. There's tumor here. There's blue ink on the bottom, right? There's normal over here. There's tumor. The tumor here is very close to this blue peripheral, right? But now it's also essentially frankly positive at this deep, right? And so you can see why calling something less than 1 millimeter unfrozen, right? Like over here, was relevant because this next slice over was positive. And so sometimes it can be hard to choose grossly, like this slice was not chosen to be frozen, even though it actually, even though it actually was closer. So just an example of why this stuff is important and how this could have been, you know, caught. All right, questions, comments?
Grossly, did it look like that other piece that permanent was? Because I know sometimes the tumor isn't always obvious grossly. So did they think grossly?
So this was obvious grossly. I don't know what prompted exactly which slice to be frozen. I don't know if this was maybe a mirror image, right, of the one that was frozen. And as you cut into it, it just got closer. You know, maybe on gross they looked exactly the same, and it was just on the histology where they became slightly farther and slightly nearer. But the tumor was obvious grossly. They selected a very appropriate specimen to freeze. Saying that it was 1 millimeter or less would have resulted in the same outcome as saying that it's positive. So hopefully that answers your question.
Yep. Thank you.
Yep.
And how do you recommend proceeding when the patient has had treatment and it's very fibrotic? I know I've ran into that on more than one occasion, and it's difficult to tell what is tumor and what's normal.
Yes, I completely agree. So that can be so fibrosis from treatment effect can be challenging. Sometimes little lobules of salivary gland tissue that look kind of white, like in the floor of mouth, can also be challenging. But I think not only color, but texture and subtle kind of features of the nearby tissue can help. So it's not always obvious though. Like sometimes like, I don't know if this is tumor or scar. And I think the best thing to do is to go over it with a couple of pairs of eyes, with a PA, with the attending, so you can all decide together what to do. If it's very white, right, and very gritty and very firm, that's more likely to be tumor. If it's more kind of, I don't know, softish, yellowish white, not so gritty, and you know the patient has had treatment and it's a little more ill-defined, that is more likely to be treatment effect. That being said, you can have islands, tiny islands of tumor in treatment effect. So, you know, it's challenging. It's very challenging. So I would say freeze what you think is the closest approximation to tumor at the closest approximation to margin and see, right? And if it's not tumor, you can go back and look at the specimen and see if anything else is more suspicious. If it is tumor, you're pretty much set. But sometimes in these kinds of cases, we've had to go back and do a couple rounds of frozens just to make sure we got everything. But yeah, it can be hard.
Okay.
So good question. Anything else right now? The other frozen specimen, I don't know if you guys got a chance to look at these, great. Did anybody have any thoughts on, I think this was number 2 in your list. This was a tonsil. Did anybody see anything going on in this tonsil?
There's something towards like the bottom.
Yeah, there's like a small focus, suspicious for invasion.
Exactly. So remember that in any mucosal specimen, it doesn't have to smack you across the face, right? The tumor, like this is completely normal in most of it. And then like, oh, wait, whoops, what's this? There's a little bit of piling up of the tissue from the frozen, maybe a little 3-dimensionality. And then like you guys were saying, there are tiny foci suspicious for tumor. There it is, right? So perhaps this little island here with increased mitoses, with some keratin pearling, with some nuclear hyperchromasia and nuclear wrinkling, all right? So these foci are not what you want to see on frozen. And so when you start to get architectural complexity, when you start to get budding off of nests, this is no longer like, okay, this is maybe mild atypia. This is to worry about, right? And so this was actually from the same patient that you just saw, where the tumor was in the very far base of tongue, and then they went and took tonsil behind it as like, I'm just going to go a little bit farther back. And in fact, there was additional tumor in that farther back component. Here's another representative portion of that very budding, branching, cytologically atypical, mitotically active carcinoma. So this would be considered essentially a positive section. I don't know that this was anatomically oriented. It was just here's a piece of tonsil. So again, this would be like this is positive. Maybe I'll skip over this one. I didn't give you this, guys, this one in the section. If we have time at the end, I'll go through it. But so I will go through this one. I think you guys got this one, which was skin. So did anybody see anything in the skin? And can you kind of guess what the patient's history might have been?
I mean, there's this whole area, let's see if I can draw, like right here.
Mm-hmm.
That's a little unusual. And then here, so I mean, it looks very, I don't know why, but it kind of looks like it was embolized at one point. I mean, was it possibly tumor that then kind of liquefied? I honestly don't think I've ever seen anything like this before. It's very unusual. Yeah, Riyam is suggesting some colloid. I don't know if this is colloid, honestly. Yeah, I mean, I thought this looked like some sort of gel. So I don't know if there's some sort of treatment of like squamous cell carcinoma that like can liquefy it and with some sort of gel or embolization.
Right. So at least, so great. You recognized it as foreign material. I think that was step one, right? So like whether it's embolic material, it's not really in a vessel, so probably not embolic material. Usually the embolic beads are kind of roundish. But yeah, this is packing. This is basically exactly packing gel foam for packing the wound for hemostasis. So this patient has had a pretty significant resection of their skin for squamous cell carcinoma before, and this is packing material, right? So again, this is another potential pitfall of what you might see grossly, like that looks white, that looks weird, that looks like it could be a lesion. Okay, it's gel foam, exactly, it's packing. So, however, what else is there on this slide? Anybody notice anything else next to the packing?
I mean, it looks like there's some islands of, let's see here, like squamous, like keratinaceous debris, and like looks like, you know, islands of squamous cell carcinoma. So looks like this is still positive. I guess I'm not exactly sure what sort of frozen this is, whether this is a margin or not, but if it's a margin, call it positive.
Yeah, so this was taken from the main specimen. So this is a perpendicular section through, you know, lesion, which is lesion being previously ulcerated, previously operated skin and adjacent nearby, right? So in the adjacent nearby, you see these very deep nests of, you know, thin, but very, very highly atypical islands with mitoses, with dyskeratosis, with nuclear hyperchromasia, pleomorphism, keratin crud. Here's even a little like activated, you know, muscular vessel. So yes, so this, we got lucky because in this case, your tumor is essentially only microscopic because all of your macroscopic disease has been resected and you're left with ulcer and gel foam. So they got lucky in that they saw this island and they were actually able to give a measurement, you know, here to deep, okay? Sometimes they can't really go any farther because if they're in scalp and they're on periosteum, like they're done. But this is another example of what you might see or might be challenging. And let's look, oh yeah, there's another thing here. Just based on the shape of this, what might it be? Hopefully you can all identify this as carcinoma, highly atypical, large.
Looks like maybe nerve invasion.
Yes, I see written and I heard perineural invasion, exactly. So a good low power, not that P&I is going to be important on your frozen necessarily, but if specimens are cauterized or can be challenging to know what's tumor and what's not tumor, sometimes the shape of the cells can help you. So these C shapes or these cup shapes that are surrounding some pale material, that is very often perineural invasion. So if you're ever uncertain whether something is tumor or not, but it has this kind of cuppy shape around what might be a pale nerve, be very, very suspicious, right? So in fact, yes, this is easier to see because the morphology is good, but yes, this is perineural invasion. But it's a good example of that kind of low power like cue that might be what you're dealing with. Questions, comments? All right. And here's the permanent remainder of that specimen. showing again the central core of gel foam here, and then these islands. There's that muscular vessel. Yep, there's now the carcinoma, which is a little bit clearer. And yep, there's more carcinoma, right? More starts to pop up. And what else? Here's that little, yep, here's that little guy with the PNI. Okay. All right, a couple more. All right, so this was, I think we said this was gingiva. Does anybody have a diagnosis for this one? Let's move around a little bit. Arguably, this part here looks less bad, but we have something kind of exophytic. Ooh. So sometimes, go ahead.
Oh, I forgot what that, it's like the verrucous something that grows all along your gingiva. Yeah, that thing, PVL. And then this definitely looks like it could be invasive foci every now and then, or at least high grade.
Okay. So, all right, 2 points. One, let's put PVL on hold for a second, because that's a diagnosis that can really only be made when you have an overview of what's going on in the whole patient's mouth. You have multiple areas, but it's a good thought that that might be what's going on in this patient. More importantly, at the time of frozen, we want to know, you kind of want to start from the worst, right? Or the lowest. Be like, is this something or is this nothing? Okay. Is this a benign squamous papilloma or non-lesional, hyperplasia, like you're saying, or do I care about this? Is this something, right? Is this high-grade dysplasia? Is this potentially carcinoma or carcinoma in situ? So when you're doing a frozen, sometimes you have to have broad strokes, right? Like, is this good or bad? Is this nothing or something, right? Is this high grade or not high grade? So for those of you who are saying, is this PVL, is this papilloma? Like, maybe there's a background of PVL or maybe there's a background of papilloma, but like there is a tripolar mitosis. Yes, thank you. There's a tripolar mitosis. There's dyskeratoses. Let's zoom out. There's very complex architectural atypia with branching, budding, nesting, exophytic growth. But when you look around, like, nope, you are not allowed to see a tripolar mitosis in a benign thing, okay? And so there's tons of mitoses. Sometimes we've talked at Sign Out how the nuclei almost look like potato-y, right? They're like a bag of potatoes. They're no longer a picket fence where they're organized very polarly and perpendicularly to the basement membrane. They now just look like a jumbled up bag of potatoes. Some are small, some are big, some have wrinkled contours, some are dark, some are light. There's tons of mitoses, right? So this bag of potatoes is not okay. So if I do not believe there was a history of PVL in this patient. So all exophytic papillary carcinomas don't necessarily come from PVL. They can, but they don't necessarily have to. I think this was just an old dude who had a very exophytic tumor, all right? So when you're looking at this on frozen, this is something, right? This is it. This is like, yes, worry about this. Whether you call this carcinoma period, whether you call this carcinoma at least in situ, whether you call this severe dysplasia worrisome for invasion, those are all the same. Those are basically all, this is it. This is lesion, all right? There's no more I can give you to make this any worse, right? Okay. So does that make sense? This is the permanent remnant. And so, I'll give you guys this presentation if you want to go through it on your own, so you can have the permanence there for comparison. But clinically, this guy had a lesion starting on the gingiva on the mandibular gingiva, and he had something protruding through to his skin. All right. So they were going to resect his segment mandible, but they found something on his skin. And so this is the same patient with a biopsy from the skin that they were worried about, like it had a rash or something. Okay. So anybody get a chance to look at this and comment on what they thought might be going on in the skin? So there's a background of,
I mean, there's a background of looks like inflammation. I mean, I think kind of similar to the previous, not the case before, but 2 cases before, there's multiple, it's like foci of carcinoma within the skin. I mean, the skin is also exhibiting some dysplasia, but I don't know if this skin, I don't think this is arising from the skin itself. I don't know if this is maybe a metastasis from a different area. It's kind of hard to say.
You want to drive and tell me where you see the carcinoma?
Well,
Want to take control of my screen?
I'll try. Okay.
Okay, hold on. I have to open.
It says I can control it. It says I am controlling it, but I'm not doing anything.
Yeah, I have to give you, hold on 1 second. I had to just change my setting. Okay. Okay. All right. Try again.
Yeah, it's kind of working, I guess. Oh no.
I'm not doing anything, so.
It's going too fast. Okay. Okay. I think I'm going, I gotta slow down with the mouse movements. I mean, I think this one was kind of, it was a little difficult, I'm not gonna lie. Because some part of these, I was like, are they just involved hair follicles?
Right.
Is this, you could imagine like, it might be extending up here. In the comments, there's a SCC and actinic keratosis. My God, sorry, this is very difficult.
Sorry. Well, let me know when you give up. I'll take back over. Yeah, so let me just talk.
Like right there, areas like here. Yeah.
Yeah, the areas like that are challenging. So there's a ton of inflammation, acute inflammation. The acute inflammation is not only in the stroma, but in the epithelium. And that can account for a significant amount of atypia, right? And so if you look at the surface, you see the surface is inflamed and atypical. So maybe AK, but I don't think it's quite yet carcinoma in situ. And then when you look at the hair follicles, they kind of have the same atypia. So you're like, okay, what's the hair follicle atypia? Like you're saying, what's carcinoma? It's all very inflamed. Well, let's keep looking. Don't give up. Don't give up just based on that. Always look deep. And always keep going, because you never know what you're going to find. So in the deep tissue, we see these like shards of keratinaceous stuff. And
Is that trying to be a tadpole?
It kind of looks like cytology, and it's trying to be a tadpole. So unfortunately, or fortunately, it doesn't matter. They aborted the surgery in this patient anyway, because it was too big for them to resect. Unfortunately, this was called negative at the time of frozen. But if you are judicious about your search, you'll find these isolated, highly atypical, keratinizing cells. This is basically cancer coming from below. Yes, so this is cancer coming from, because there's not too much, most of this is deep. Now I see this. Yes, there's only some atypia in the surface, a ton of inflammation, but there's no obvious carcinoma coming down from the surface of the skin, right? If you look on low power, now bird's eye view is helpful. Now you're like, wait, I think these are mostly hair follicles with a ton of inflammation and solar elastosis. So there's probably some AK. But yes, this is gingival mucosal carcinoma coming from inside, eroding out into the skin, and therefore the islands of carcinoma that you're seeing are that's a little blurry, sorry about that, are these very, very deeply keratinizing little tadpoles with giant wrinkly nuclei. But since this is a keratinizing carcinoma, you know, you still have cytoplasmic keratin, you still see the cytoplasm, but this is too atypical for nothing. And it's random, like single cells floating in the middle of an inflammatory debris. So this was the invasive component of this, which we just saw, right? This exophytic papillary. So this was a really, 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 really nasty tumor, even though it was histologically very well differentiated, okay? So I'll send you this. Oh, it's 9:04. I'm so sorry. I know you can leave if you want to. So this is the permanent remnant of that tissue that you guys can look over on your own, but it is super hard to interpret because of all of this inflammation. But if you look carefully, inflammation, what are all these dyskeratotic, single, hyperchromatic cells doing? Those are cancer cells. Okay. Oh, there's another, maybe an island there. Okay, if you want, I can do the last two pretty quickly, or you can tell me what you saw, whatever. Base of tongue. I think this was base of tongue. So something or nothing?
Something.
Something. Cancer or not cancer?
It's a tumor and it has basaloid appearance.
Mm-hmm.
So there is kind of microglandular configuration in some areas.
Oh, do you mean this basement membrane like?
Yes, here. Is it salivary gland
material rather than?
Is it salivary gland tumor or something like this?
Okay, so that's one option. If you were to give it a name, what would you give it? At least we think it's tumor. Yes, at least we think it's tumor. Is anybody convinced that this is not tumor? No, everybody thinks this is tumor. Whoa. Does anybody think this is not carcinoma? Does anybody think this is lymphoma or melanoma?
It's carcinoma. It's kind of low grade, something like this.
Okay.
Adenocarcinoma.
All right. We have one vote for basaloid, one vote for non-keratinizing SCC, one vote for not heme, another vote for non-keratinizing SCC. All right, so we got both Heathers on the same page. So tell me, one of you or both of you, tell me about why you came to that conclusion.
I guess because it still looks like epithelioid and vaguely squammy, but I don't really see a whole lot of like pink in here. Because I know you don't really have to see like obvious like keratin pearls or anything for it to be keratinizing. You just have to see like a lot of pink, but because you can still have like some keratin in like non-keratinizing SCC, but just like the overall picture is like very, very blue.
Yeah, and I would agree. I think usually like non-keratinizing SCC tend to be a little more basaloid in my, I guess, limited experience. So this is what it sort of reminded me of. I mean, this is definitely carcinoma. There's the mite, huge mite there.
Yep.
Just to echo.
Excellent. So yeah, you guys are right. So if you got to carcinoma, excellent. That's all they need to know on frozen. This is carcinoma. You got it. So generally when they're not, so now we've moved on a little bit. Again, I'm so sorry I'm over time, but those of you who can stay, thank you. We are no longer in a margin category. This was just a frozen of lesion, right? So they're looking for lesion. And so if you can tell them, yes, you're good, right? So yes, this is carcinoma. They're done. They found it. And so in in the base of tongue and tonsil, okay, one mitosis, another mitosis, a lot of associated maybe small inflammatory cells, another mitosis, very blue, very basaloid, like you said. So in the base of tongue and tonsil, inevitably, what are we dealing with this morphology? Not only a non-keratinizing SCC, but specifically why does this person have this tumor?
HPV.
Thank you. Okay, so don't forget that base of tongue and tonsil are special sites, right? Where these very blue, very basaloid appearing carcinomas are essentially inevitably non-keratinizing squamous cell carcinomas or pauci-keratinizing squamous cell carcinomas that are HPV related, okay? And so when you see this in a tongue, base of tongue or tonsil, and look, you see the relatively normal surface epithelium right here. These are deep crypt originating tumors. So please don't stress yourself out about whether this is invasive or in situ, or whether these, these basaloid islands are, again, invasive or in situ. This is all invasive carcinoma. Don't worry about it. Just call it carcinoma and move on, right? You can see the surface here. This is obviously deeper than the surface. This is invasion. Okay. And I've provided you your permanence here so you can compare. The problem with base of tongue and tonsil is that you're always dealing with blue on blue, right? You're dealing with blue tumor on top of blue lymphocytes, and it can be very challenging, but I think you guys have gotten it. Okay. So the last one, oh, actually, let me go back there. If you look closely, you do see some, eosinophilic keratinization. I think a lot of this pink stuff that you're seeing is actually basement membrane material rather than lumina of a glandular phenotype. I think this is just eosinophilic basement membrane material. So I would not consider this necessarily to be a glandular forming cancer. I think it's just cells wrapping around stroma. Okay, and then the last one is also base of tongue. Again, just searching for primary type of thing. It's also kind of inflamed. Did anybody see anything here? Oh yeah, you got a circle. I'm gonna move it into the circle. Well done. All right, so here's your tiny, tiny, tiny little fragment of something that's totally disoriented, but extremely wildly pleomorphic, giant nucleus, mite. Again, so what's your diagnosis here?
Squamous cell carcinoma.
Squamous cell carcinoma, right? So if you don't have to, if they're not asking you to hem and haw about invasion versus non-invasion, oh, look, there it's probably invasive. If you see this, look, a potate. If you see this fragmented thing, just call it carcinoma and move on. And so unlike the other case, how would you, oh, look, here's another fragment. How would you qualify this one? Keratinizing.
Looks keratinizing.
Yeah, keratinizing, exactly. So not because you have abundant keratin pearls and exophytic like stuff like we saw in the other case, but you have just a ton of intracytoplasmic keratin and the cells are very pink, right? So this is no longer blue on blue. This is increasing cytoplasmic pink. There's a nice tripolar mitosis, all right? So this is a keratinizing carcinoma. So this is not HPV related, all right? But you got to look hard, right? Don't forget that there are multiple pieces of tissue and the tumor's not on all of them. It's only on some of them, okay? And so I've given you the remnant, which arguably, like, there's a lot more tissue left that hasn't been, faced, but it's okay because you got the carcinoma. You got the carcinoma on your first faced section. I think it was quite hard to see here because it got, now it got cut through, but oh, there it is. All right, so here's the carcinoma. So the second point of this case is, yes, they do taste good, those potatoes. The second point is, if you ever have a piece of tissue like this unfrozen and you don't see cancer, think about what could be remaining in the chuck, right? And get deepers. please don't ever be afraid to get deepers when you're not seeing what you think you should see. And that's my last point. All right. Questions, comments, concerns? Was this okay? Was this useful?
Yeah.
Okay.